Same thing, when I go transverse, I'm transverse on it now, see? If I go like that, that's the pelvic bone. This is the pelvic, see? I can't see anything here. See that shadow? That black stuff, that's the pelvic bone, okay? So to get to see the rest of the urethra, what I do, if I go back, now this is the colon to the right. See that shadow to the right? Is the colon, right? So if I go back, if I keep going back, I push down and I look back. See? I'm still following the urethra. Look, all that urethra. See it? On top of the colon. Dr. Badur, can you point at the colon to the right?
This one?
That's the colon. On top of it?
This one?
Yeah, this is it, right? So you can follow it all the way to the back. All the way, see? All the way to the back. Look at my probe. Can you take light on, please? Can we get that, or like put someone, yeah. Look at my probe. See my probe position? Can everyone look at my probe? Yeah. See? The probe is just, look at that. Okay? So everyone is looking at the bladder, will be looking like this, but you're like looking like that. Okay? All right, here you go, doc. So can you please reproduce this? Now, go back to the bladder. Yeah. Now your sides are very good. Okay, good, better. Yeah, but now stop and take a picture of the urethra. All right.
This one.
But no. Like,
This
give
one.
me the bladder as well. Give me the bladder the way. Yeah, perfect, perfect. All right, decrease your pressure. There you go. Okay, freeze. 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 Go back. Go back. Go back. Go back. Go back. Yes. Go back a little bit more. All right, I'll take that one. You know, you can take that one and image it. Right. Now, since you're at, yeah, that one's better actually. Yeah. Now you can go transverse on it. Go back until you find the appropriate one, right? Sorry. Okay, just stay there for a second. Stay there for a second. Stay there for a second. Sorry. So, move back a little bit. Okay, so this is the colon here, okay? This is the colon in sagittal. So the bladder's neck is here, and here is the bladder itself, right? Now, this is the colon wall. It starts from here, goes down. Why can I not see underneath it? Because the colon has feces and or gas. And the ultrasound is not friend with gas, so it's not gonna go through it. But I know that these are the layers in here, okay? These are the colon layer. It's so important that you know how the layers look like. And it's so important that you can differentiate the layers. Because the moment you start to lose the layering details, that's the moment you start to think about cancer. Okay? A lot of times cancer, yes. And either intestinal cancer, colon cancer, you know, stomach. When at the very, very beginning, before it makes a mass, you start to see thickening with loss of layering details. It depends when did you catch it. But the layering details, and you can see how they're like all, you know, parallel to each other. Okay?
So at this image, the layer of the colon is fine.
Correct.
The details is fine.
Yes. Okay. And then we can measure it. We'll show you how to measure it later. Okay. All right. So.
And the whitening is normal due to feces inside. Or?
Correct. So if this dog has diarrhea, you'll see fluid in here, and after the fluid, you'll be able to see the other end of the layering, right? But you're only able to see this layer because there's gas, which is supposed to have gas or feces, right? So if you see this, now be extremely careful because I know of a vet one time before she was going to surgery for a pyometra, and then after she shaved and everything, the dog had diarrhea. So she did the good thing, she stopped. She called me, she said, Mohamed, come and scan the dog. I went in there, I scanned the dog. And the fluid was within the colon. So it's so important because fluid in the colon, if it's like the dog having like really watery diarrhea, it will look just like pyometra if you do not know how the walls look like. It wasn't. She didn't do the surgery, right? So you need to know how the colon will look like. And if you're not sure, just find where the uterus is. Colon, uterus. So if you only have one fluid-filled structure, where's the colon? Okay? So yeah, that should be a hint to her. Okay?
Okay.
All right. So let's go back.
Sometimes the confusion comes with this hyperechogenicity.
Like this is. Can you go transverse on this one, please? Transverse. Yeah. So the colon normally when you transfer it will look like this. That's perfect. Okay.
Yes.
I normally take a picture of that as well. Okay. Can you make this really big in here? Big. Transfers.
Okay, this is a bladder and this is a way.
This is the colon.
Colon, bladder. All right. All right. Let's go back to the bladder. So you haven't done the sagittal. Have you done the transverse for the neck? You haven't done the transverse to the neck, right? Okay. So this way it doesn't take you a long time when you're scanning at your practice. You have to, okay. You start sagittal. If you are gonna start sagittal, I normally start transverse. Start transverse. Do all the way up and down. Then do
That's inside the urinary bladder.
transverse, sagittal all the way back and down. So what do you guys think this is?
Blood clot.
Blood clot.
Yeah, that's probably a blood clot. So follow it. Decrease your pressure a little bit.
I think it's keep
Stop for a
moving.
second. Stop for a second. Stop. Freeze. I mean, freeze. Go back. Scroll back. Scroll back. Scroll back. 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 More. Stop. Stop. See, this is it. I can see the wall. Okay. So it's so important that you see the wall and measure it. Okay. And look at the wall detail. So the inside of the wall, you want to see how smooth it is, right? Now, can I judge this wall? Thickness? No, why?
It's not full.
It's not full, thank you, right? So it's not full, so you can't really tell if it is thickened or not.
Yeah.
So if I can't really tell and I have some suspicion, I'll just give it some fluids. Give the dog some fluid, have him stay for a while and just rescan him again. All right? Okay, great. Now, how do I know this is a clot or not?
Moving under.
Doppler. I'll put Doppler. A clot does not. So what does Doppler do? It will show you the flow. Okay, the blood flow. Where's the probe or towards the probe? Away from the probe. A clot does not have blood flow. A mass does. So if you put Doppler in this one, it shouldn't take any color. But keep in mind, the Doppler works by movement. So if your probe is moving, you may have false positive in here and think this is a mass. Good surgery find nothing.
So we
right?
should do it in freezing picture.
Two things. No, it has to be moving. But your probe has to be stationary. Okay. So two things you have to do in here. First, look at the actual put the colors. But what if you only have 2D? Follow it. Follow it back and forth. You know, shake it.
So if there is no attachment like here.
If there's no attachment,
so it's
then
not
yeah,
connecting.
okay. Shake it. Sometimes when you shake it, it will break,
Yeah.
right? Put the dog upside down. Put him on the side, right side, left side. Just keep moving that patient, okay? All right, let's go back. Collect your pictures. Stop for a sec. So here is the wall. So why I took this here to measure, if I were to measure it, because I can see the wall of the abdomen and I can see it's here. So try to take, when you're measuring, try to take sharp edges. Sharp from here and sharp from here. So you can actually get like an actual measurement, right? All right, keep going down. So you're scanning all the way right and left, all the way, keep going. And I'm starting to see little, see it's going, it's escaping from you. Put it in the middle. Keep your organ always in the middle.
The depth is fine with you?
I'm sorry?
The depth is fine? Or we
The
need
depth
to-
is okay, yeah. Keep going, keep going.
That's what I'm saying.
Yeah. Go all the way to the other end. Okay, so there's some sand in here. Are you transverse now?
Yeah.
Okay, can you stop for a second here? Okay, so why the sand is sitting on this side? What's this side here?
That's right. Dependent side.
Dependent side. That's the thing. So it's so crucial and important when you do an ultrasound, you do it on the side, do it on the side forever. You do it in the back, do it in the back forever. Because to me, first thing will come to me, well, this is the gravity dependent. No, because he has it sitting on the right side. So this is the gravity part. That's why we have it here. Okay? So when I say shake it, things should go this way with gravity, right? Yeah? Now, if you put them on the other side, these will be here. On the back, they'll be here. Standing, so you have to keep just asking yourselves about the position. All right, keep going.
So this is crystals, right?
Well, so the difference between crystals and the stones. Can you keep going? Can we tell what's the difference? Can anyone tell us the difference?
The acrostic shadow.
The shadow, but what if there's sand like?
It's keep moving in between the sides.
Yeah, exactly. So he's shaking them, right?
He's sitting and they didn't.
So let me ask you. So what's the vet now? You guys are all the referral person, okay? But when you're doing that, you're looking at the colon wall still. So I'll bring this up and bring this down. Yeah. Now zoom in more. 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 That's it. Okay. Now can you stop? Can you increase the frequency a little bit? Now now we're gonna try to look at the colon wall, and I'm just saying that in case you see like a cancerous case or whatever, you may see that. So try to go higher with the frequency. I'm looking at the wall that's about 1.5 millimeter in here.
I think it's the highest now. You can use a flat probe.
That's the highest. Okay.
You can use a flat probe if you like.
You can use a flat probe. So if I see some suspicion, I will use a flat probe. But for this, I'll just keep going because it looks normal to me. Okay. But keep going. Keep going. So if I find something abnormal, now, okay, don't let it go. Don't let it escape from you. Just keep it in the middle and follow it. That should take you to the right cadence. Bless you. Stop for a second here. Stop. Oh, stop. Stop. Freeze. 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 Go back. Freeze and go back. Go back. Back, back, back. Back, back, back. When it was here. When it was more. More. Stop. Okay. So, see, I talked about the details before. This is gas in the colon. Okay. The first black line underneath it is the mucosa, right? So after the gas or the feces is the mucosa, and then the white one will be submucosa, and then the black one would be, and then the serosa. Okay, so I now will see all the layers. So being able to see the layers and differentiate them is a good thing. Okay, all right. So can we all appreciate that? Now, if we were to measure it, can you measure it, please? I'll measure it from like, yeah, just about there, yeah. Two, yeah, up, more. That's it. Probably measure this much, so it's normal, right? Then I take an image of that and I save it, right? Move on. Now, when you're there, this is the aortic trifurcation. This is the aorta. Go back up. No, cranial. That's it. It's 1. If you move back, it will become 3. Okay. Go up. Now you have to increase your depth a little bit.
Aortic bifurcation is cava.
So the cava. Okay, go back. Cava and aorta. So once you move back, that will become 3. And these here, where you're gonna find the iliac lymph nodes. Okay, so the iliac lymph nodes are when they
bifurcation.
When they become, if you're concerned about cancer, metastasis, a lot of times they'll go there. You see that? See, it was 3 here. They join to be 1. Okay, so as you go cranial, it'll be only 1. You go caudal, it'll be 3. All right, now go back to the colon. Where's the colon? All right. Keep it in the middle. Don't lose it. Look left. Don't lose it. Maybe because the dog on the back, that's why?
Yes.
If you're comfortable with the dog on the side, put him back on the side.
That's okay.
All right. Just make sure you keep him in the middle. You're not sagittal, right?
Yes.
Okay. You see how the small intestine look like?
Yeah.
The coffee beans? Don't let that one escape from you. Put it in the middle, Up. Here's the kidney.
Yeah.
Okay, so we'll leave the colon aside for now. Okay. Now, go back to the colon. So in cats, are you able, now at this level, the colon is gonna become transverse, right? So for him to stay transverse, he's transverse in the colon, right? To stay transverse in the colon, he has to turn sagittal on the dog. So I'm going like this to follow the colon. Like the colon is a question mark, right? Yeah?
Yes.
Like right now it's a big question mark. That's how the colon come in. So if I'm transverse in here, I'm transverse, I have to go like that to stay transverse in the colon. Make sense? Okay? So, all right, go back. Keep following the colon. It's a bit harder to follow the colon, okay? So we'll just, for the purpose of what we're doing today, stay with the kidney now. Okay. So the kidney, here's the kidney in transverse, all right? There are 10 doctors in here. They all sending you the cases to do the ultrasound. What would be the doctor question to you when you could tell them there is some bladder stuff? What would be the question?
Need to do surgery?
Surgery or not? They don't care what you tell them, crystals, whatever. Surgery or not, right? So we're gonna try to shake it. We're gonna try to break all these together and measure the biggest one. Is this a boy or girl? It's a girl, so there's a higher chance she can pass lots of things, right? So we shake it and see if they'll pass or not, okay? Until the biggest one.
He shake it, but it doesn't
You
move.
shake it but didn't dissolve.
Well, did he shake it good enough?
No, one thing I want to ask.
Yeah.
This so they're giving like a beeline artifact underneath. So how are you going to compare as a crystal?
Which one?
You know the crystals? There are some beelines forming.
You mean-
That will also form if there is air inside the bladder, right?
Here inside the bladder.
Like for example, let me do the cursor here. For example, below this,
Yeah.
there is some artifact appearing.
Yeah.
That also appears with the air as well.
So normally air, okay. So normally air, when the dog on the back, you'll see the air here. It wouldn't be here because air will go with opposite of gravity. Now, if this is air, you'll see it here, right?
I'm trying to say.
But these are suspended. These are suspended.
Amphisematous cystitis.
I'm sorry.
Amphisematous
If
cystitis.
I wish if unfortunately my computer died. I had a few pictures that
I mean that
I
will
wanted
be
to show
the
you.
same artifact, right?
Emphysematous cystitis will be up
But artifact will be
against
same,
the
right?
gravity. I'm sorry.
It will be the same artifact which is appearing here, kind of.
No, it'll be a little bit different. You'll see it almost like a curtain. You know how the curtain side look with the thorax, when you look at the thorax, how the curtain side where the diaphragm hits the abdomen, it will look more the same, right?
So it should be more pronounced basically.
And the location as well. Okay.
Alright.
So the location, air is not gonna sit in here. If you're not sure, just shake it, right? So please shake it. Yeah.
Could there be any confusion between the gas in the colon and the hyperechogenicity of the minerals or the crystals?
Yeah. So stop here, please. That's a good question.
Yeah.
I can see the wall of the bladder and the wall of the colon and this one inside. Sometimes this can be pushing in, but I can tell that the wall
This is space.
out and this is in.
So under any circumstances, I should see the layers. However, the amount of gas in the colon.
Shake it. Shake the bladder.
Okay.
Put it upside down. The colon's not gonna go the opposite side when you put it. So it's not just collecting it, it's just like making sure.
Okay,
Yeah.
sorry please. And the
Colon?
white lining will be outside, not inside the bladder in any means?
Yes,
not
exactly.
like here.
Yes.
The colon here
This is a very good shot. See the bladder wall inside? So this is the mucosa wall of the bladder, mucosa,
Yeah.
right?
Okay.
And what is this? Stone inside the mucosa. I mean,
Yeah.
sitting on the mucosa. Versus this one, the mucosa of the bladder is here, and these are the colon wall, and this is the colon.
Cool. Okay.
Good.
Thank you.
All right.
So now it's stones, right?
Well, we don't know. We don't have break it, right?
Sorry?
So did you scan it right and left, up and down, both? And you took pictures? This is, yeah, he's transverse now, all the way to the other side, all the way, perfect. So now he tells, sometimes with these guys I take a video. You have a good hard disk, just take a video, right? So you have it there, right? Good. All right, did you put color on the Doppler, on the... See, so I can tell that there's a blood vessel in here, right? That's a blood vessel, right? I don't see any vessels in here. Just keep in mind, sometimes tumors, what happened to tumor? Okay, you get a blood vessel giving blood to the tumor. So normally you see blood inside the tumor, but sometimes these tumors, they just grow like crazy. They don't grow normal blood vessels, right? They don't do that. So they can actually die off. That's why when you get a spleen mass, it ruptures because it doesn't have, good blood supply. So some of these cells will die off. And that's why when you get a biopsy from a tumor, do not get it from the center. Get it from the periphery. If you see a mass this big, don't go right in the middle. You may not really get that good sample. The good sample will go through the edges from normal and abnormal cells. Okay? So sometimes, keep in mind, sometimes tumors do not have blood vessels. So not having a negative, don't use the color as okay, I don't see it. All right? Maybe you have PRF, you have your PRF so high. Can you please play with the PRF, Morgan? Or you guys? So we know that this is a blood vessel. Don't move the book, please. So he made all the little ones disappear, okay? And he made this one appear. That's an artifact, I can tell. How does he do that? He's telling the machine measure the flow of the blood with the highest flow. He's telling like how much velocity is going through it, right? So now he's making all that disappear. So it also has to do with the PRF. So if you bring the PRF down, now you start to see all the little ones. See, now you're starting to see these guys, right? Right? So the thing about, well, that's probably like an artifact also. Yeah, that's an artifact. But what I'm trying to say is the machine setting plays a big role of what you see in there, okay? But use other things. So if you have, like honestly, like 90% of your diagnosis should be based on 2D images. And the color just to confirm.
You can use the power doctor as well.
Yeah.
That will help more.
See now, like this here, I know that this is a vessel in here, but if he plays with the PRF, he can make it disappear. So adjust the machine accordingly. So look at that. See? Go back where you were. Go up, where? Here you go. So this is probably one. But see, it's too bright now. Adjust your image. The more you're working, every time you move something, you have to adjust your image. So drop your gain a little bit. Drop your gain slightly. That's about okay. Now you can try to shake this. So I know that this is one for sure. I'll try to shake it. This is about like 0.4 centimeter. How about the big one? It's about a centimeter, right? And now what is this here?
It's blood clotting.
Hmm?
Part of blood clot.
Well, we have to shake it. We can shake it and see because it's close to the wall. But now, what happened now is like we changed the gravity side. So the gravity is this way now.
This one is sand, right?
I'm sorry?
It's a sediment, right?
Decrease your pressure a little bit. Decrease your pressure.
It's not a stone, right?
Well, we have to shake it. This one, shake it.
It doesn't look like a stone.
Shake. So we're able to separate these together, right? This from these, right? So I know that this is about half a centimeter, but this one is a bit bigger, right? So we need to get comfortable with this one. Okay.
It's
So
not a stone. The big one is not a stone, right?
well, it is shadowing heavy enough, right?
I mean,
So it-
but the stone should be like curved, kind of.
You mean smooth?
I mean, it should have like
Have
some,
stable shape.
some curved shape or some circular structure. But it's
No.
just sitting there and it doesn't.
Yeah. Yeah.
It's sitting on the wall.
Yeah. So there is a again. It's a very good chance these could be like little sediments.
Sediments, yeah.
As like little stones, but the sediments is like sugar, like or salt, like if you get like rough, like coarse sugar, how they look like pieces of sugar, right? If it is bigger than 2 millimeters, it's a stone, right? I don't care about what you name it, but it's all about the size, right? So
now the blood clot is in the new film.
yeah, so it's actually swimming, right? It's swimming.
Because of the pressure.
Okay. There you go. So what to do with this one? We can put the dog in a standing position, right? Now put the dog in the bag, but try to shake it again. Try to shake it. And go back. Go back to.
But why is it still up, the blood clot?
It's just swimming.
Just
Right? Yeah.
I think the pressure is forcing the near field down to the blood.
He's putting also more pressure in there, but it's just like it can swim like that, right?
This one.
As far as it's not attached to the wall,
So this one, if we do the X-ray,
you're not gonna see it.
only the stones.
And well,
Might be, might no.
you'll see. So you'll see the stones if they have enough mineralization in them, okay,
But we can miss a lot of diagnosis. By
and if they're not made of cysteine or urates, right? Cysteine and urates, you don't see on X-ray. I can't see you. See you. Cysteine and urates. Yeah, there's a good chance, but we'll go back to it when we put the dog on the standing. So we'll put the dog in the standing position, and that also will make it move. So can you zoom out one, please? Okay. Sorry, this light is yeah. Okay. So I can look at the kidney from here, right? How do you like this picture?
It's too big.
See, like, yeah. So if I drop the probe like this, see now, right? So what do I do? Okay, all I want you to do now is look at my probe. Look at my probe. Just don't look at the dog. Look at my probe. See how is the probe orienting on the table, like this. Okay. The kidney, I know the kidney is here. I can't look at from here or from here or from here. But the good picture is to come from here. The further down you look, the better the image you'll get. See? You'll see just that renal pelvis at the distal 1/3. Okay? And now when you're scanning, you want to get to learn how to get the kidney in a position just like that. So if you don't want to have it to be like, oblique like this or oblique like that, right? Try to get it right, nice like that. Now see, I'm pushing the kidney, I'm making it flat, decrease the pressure, right? See what's here is the colon. So I just have to push the colon away with the probe. So it has to do a lot with the pressure that you're doing, okay? So that's the kidney, right? Okay. Now, once you get that nice sagittal, I go transverse, right? You see that alligator?
Yeah.
You see that? These are the ribs, right?
Yeah.
Okay, so
You see the alligator?
yeah.
Good. You see the nose?
Yes.
No, what is
Anyone
it?
doesn't? Do you know what the alligator is?
Yeah.
Okay.
Yeah.
You do?
But what is that?
No?
The rib side.
Okay.
Yeah.
So the alligator eyes are the ribs. If you look
Yeah.
at these two, can someone point at them, please?
Here, this the eye,
So
and this the eye,
these
the nose.
these eyes. And that nose, can you point at the nose bridge, please? That's a nose bridge. Right?
No, this one.
Yeah, that's right. That's right. And that movement is the specular. Can you zoom in, please? Zoom in, big time. Big time, big time. More. That's it. Okay, bring that focus point up. Perfect. So that alligator eyes, the two eyes, and then what's that line? The nose is what?
That's
What's the nose?
So glide sign.
It's the glide sign. What's that glide sign represent?
The lungs. There's
No pneumothorax, and that means what? That means that which layers are touching each other?
That's
no.
right.
And the parietal layer of two layers.
Okay. So, yeah. Okay. So for those of you who were not here with okay, I'll show you really quick here. So what I want to say is, I want to say that I'm getting the kidney here between the ribs, and I'm gonna do it sagittal, same thing here between the ribs. Okay. Like that.
What happened?
I was doing before.
Yeah.
From
And then
this
the
way
picture.
and go
Can you zoom?
and go
can
like
you play with the zoom a
what we
little
are doing now.
Zoom out.
This is what I was doing before.
See now the kidney is gonna be what?
Not
Standing.
Not good, yeah. Not
Right?
good, yeah.
Standing. To get it to sit, you have to look like that.
Okay.
But now it's sitting outside my screen, so I have to slide cranial to get it.
Okay.
Okay? So you need to, here you go, Doctor. So Oh, so let's go back to that alligator for those of you who weren't here. Okay, so really quick here, the alligator. Once you do it, get us a good picture and I'll go stand over here.
Is the last intercostal space different? Last
Not
intercostal.
necessarily lost. Where you get the good picture.
Okay.
Okay. Sometimes it's like because if you go further, create what you're getting.
The creamy pool.
What?
The creamy.
The alligator eyes, which is this and this, represent the ribs. So the rib has a shadow underneath it. It's black because the sound doesn't go through it. So black, black. These are the alligator eyes, and this is here the nose. Eyes and nose. If you're looking at the alligator in the face, like you're looking at the alligator, good. And then that movement here, that is a slide sign. So that's pickling. Bless you, alhamdulillah. So this pickling is the movement between the parietal and the pleural, parietal and visceral pleural, the two layers. So when they go against each other, we see this. So we know that the parietal is attached to the thoracic cavity, and the visceral is attached to the lungs. So when these two layers are touching each other, I know that the lung is touching the thoracic cavity, and there's nothing in between, so there's no pneumothorax. Okay? So having that movement is a proof that you do not have pneumothorax at this site, at this particular site. So if you look everywhere else and there's no air, you know, and you follow that T fast, thanks so much. Right? Awesome. All right, I'll keep going. Pilectasia or hydronephrosis. Urethral stone, yeah.
Masses.
Masses. Pyelonephritis is the big one. Okay, pyelonephritis. Okay, so again, like I'm looking at the ultrasound, trying to think, okay, how can I help this dog? Okay, well, I can write a big report, but how can I help the dog? Yeah, pyelonephritis. Yeah. Yeah. So basically, any problem with the kidney, I want to know if it's infectious, okay, or if it is obstructive, right, or if it is inflammatory or cancerous, right?
Hypertension also.
Yeah, but for now, like the one thing, the few things that we're gonna look at the renal pelvis, right? The renal pelvis will get filled with urine when the kidney is overworking, right?
Yes.
Working a lot, right? So what will make the kidney work a lot?
Blood cirrhosis.
PUPD, like what? Diabetes, Cushing's. What about this dog? What is this dog getting?
Sorry?
This dog is getting what? Treatment. What treatment is the dog? Prednisone.
Cortisone.
Right? So he's getting cortisone. So he gave you pilectasia. A little bit of pilectasia is okay for a dog getting prednisone. What if you have a dog in hospital and you have him in hospital for 2 days and you do ultrasound and you find dilated a little bit of pilectasia? Where that could be from? Fluid therapy. You are making urine now. So you expect the renal pelvis to be a little bit dilated, okay? So whenever I have dilated renal pelvis, I think about all of these things. I put these at my every report. If you look at any of my reports, you'll have all these listed there as a potential differential diagnosis, right? So in your description, in your ultrasound report, you're gonna write there is a 5 millimeter by 5 millimeter round anechoic thin-walled cyst-like structure. I will never say a cyst. Don't say a cyst. A cyst-like structure. It looks like a cyst, right?
Yeah, safe yourself,
Cyst-like
but
structure.
don't
Yeah.
be more sure.
Right? Yeah. Well, if you know, it sounds like a dog and walks like a dog, it's probably a dog, right? Right? But when you're describing this, you describe it the way it looks. In your comments down south, you tell, okay, well, here is what I think this is. Okay? Because it could be an emerging cancer. Who knows? This very extremely unlikely. This is a test. You know, it looks like a cyst, but I'm talking about like something in the liver, something in somewhere else, right? So this is a cyst. So a single cyst, is that a problem in the kidney? Is this polycystic kidney disease? No, right? It's just like a simple cyst. So what do I tell the owner? I'm gonna tell her bladder, cyst, liver, all these things. What do I tell her about this? Just incidental finding, right? We'll just keep an eye on it, right? So, thank you so much. Thank you.
So much noise.
Do we drain the cyst? Should we drain this cyst?
The meaning keeping high.
Anyone goes for a yes?
No.
What if it gets bigger?
Yeah, how should
Bigger
we know the
and
owner?
bigger and bigger.
I think I will only drain it if it is causing obstruction at the level of the appendix. Otherwise, it's going to drain.
So if it is causing, sometimes I've seen this cyst like humongous cyst. أنا صح زي دكتور زي دكتور أنا صح زي دكتور.
Doctor, meaning keep an eye. يعني هي
Yeah.
keep an eye. You told the owner keep an eye.
Keep an eye as in recheck it again in 2 to 3 months,
Oh,
right?
okay.
Okay. So yeah. So back to the cyst again, okay? So do we? Cyst-like thing. See, you're pressuring the kidney, right? Still, decrease your pressure. Slide down. Slide your probe down. Okay. Twist the probe a little bit. Okay. Sorry. You go to the twist. So see that movement? And then drop it a little bit like that. Sorry. Okay.
Maybe reverse.
Yeah. Sorry. So the other thing that you were talking about is the decrease in the corticomedullary details, right? So you'll be able to tell the cortex from the medulla, right? So when you start to get loss of that or decrease of that, what do you think? What do you start to get concerned about?
Chronic kidney disease.
I'm sorry?
CKD.
Yeah, what else?
Chronic kidney disease. Age. Just an age change.
Yeah.
Yeah. It's nothing.
Okay, are you able to, I'll probably measure this one as well, just like measure this one here. Shadowing, right? And sometimes you get just like one of these little stones that can give you that cyst, right? It give you basically like more like a physical obstruction, right? I'll probably go from here to here. And just keep in mind that shadowing has to do with how much mineral inside it, right? Right? So it can be just not that mineralized, so it may not shadow as much, right?
It's not really shadowing. This one.
It is, yeah, it is not shadowing, yeah.
Not shadowing this one.
Yeah, but there's a little bit of shadow.
At some point,
Yeah, that's what I'm saying, like it depends. So the whole thing is not shadowing, right? But just move it until you get a good area of shadow and then you can measure that area. So unfreeze and freeze back. See that.
Yeah.
Yeah.
It's from big, right?
Now you see, I can see you're still doing a little bit of pressure from here. Sometimes you can have kidney indentation. So when you get like an old infarction, you can see like an indentation, which doesn't mean anything. You just note it in your report.
what's that?
Indentation. So they get infarction, and then that will cause a little bit of indentation, like like pushed in, right? See, like there's not good details here between the medullary and the cortex, right? So you notice in that there's decreased cortex medullary details, and a 10 or 11 years old dog, okay, well there's not a whole lot you can do for it, right?
Okay, Dr. But
Yeah. How about it? Okay. So when we're looking at these, we have to keep in mind that this dog is getting prednisone, right? That's why the history is so important, right? All right.
Yes.
Move on.
One thing I wanted to focus as well, they always say that we should focus on this free mucocale vein as well.
Yeah.
So because this is the one which is going to get the thrombus and stuff. But sometimes it's difficult to. This is where we should focus, right?
Yeah.
Kind of here, right?
Yeah.
Yeah.
Yes, exactly.
Yeah.
Yeah. But you may want to increase your PRF a little bit and move this up.
it's for perinephric.
Front abdominal vein. Yeah. The trench right in the middle. But again, let's move on. Yeah, I know you're doing advanced stuff, but we're trying.
I want to.
You find that right kidney, And you like how you scoop the ice cream?
Okay, I know.
Just like that. You know, okay, great. So
I like ice cream.
yeah, here you go.
Turkish ice cream is different.
Yeah.
Turkish one different.
I wish if all of us have more cases, obviously I will let you all practice on them, but because this is a client-owned case, we're not allowed. We're only allowed the vet who brought them into.
Yeah.
And you have a contact problem. I'll put
Yeah.
some
So basically, what happens like
some color in there. Just
yeah.
yeah, I'll fill that. Now you'll be able to follow the whole spleen all the way back and all the way back and forth. The spleen. Remember, I told you earlier that I do the zigzag. I found some stuff before from the zigzag that I didn't find earlier because I did not do the full job at that time, right, when I was looking at it. So you need to look at the whole thing in sagittal and in transverse.
Let's look at the pancreas as well.
Okay. So after the spleen, let's move up to the.
Pancreas.
I normally move to the liver.
Okay. Usually I look at
Again, you have to develop your own technique.
Yeah.
So, but stick to it every single time. So let's move up to the liver, please.
Alright.
Okay. So remember, if you remember from yesterday, when we get the liver, what we do, you're able to fill. See down here, right? So how do I do that?
Decrease
The depth. Okay. Give me like more like 7 centimeter, please. Okay. That's what. Okay.
Looks slightly smaller liver.
So go all the way right and all the way left. So we know that this dog having liver problems, right?
Yes.
Or increased liver values.
And there is some shadowing happening here. See that?
Yeah.
This thing. So what's this? Polyps. Yeah. Polyps are biliary system. There is stones in the biliary system.
Yes.
Now we're finding the
Put some color on it as well to confirm and prove that this is not a vessel, right?
there's a twinkle artifact there, so which also proves
I'm sorry?
there's a twinkle artifact,
Yeah.
so which means there's a stone there.
Yeah.
Yeah. So incidental finding, I would say.
It is incidental finding.
Yeah.
And what that can explain from this particular dog?
I mean, the ALP is high because of this.
ALT and what else? And the ALP. The
ALP is because
ALP.
of this.
Right? Yeah.
So there's a cholestasis.
So,
happening.
yeah. And just remember, whenever you get cholestasis, whenever you have, cholestasis, you can have secondary increase in the ALT caused by, the cholestasis. All right, so go back.
There's a mucocale developing here or what?
Oh, let's take a look and see.
It's a mucocale.
So
Yeah.
just decrease your pressure a little bit. I'm sorry, decrease your frequency.
Yeah.
I mean, increase. You know what I'm talking about. And you want to be able to look at the whole thing. So I push in a little bit, and Kiva was coming through, and then you see the whole thing. Now, if I go like this, it will disappear, but if I push in and I go like this, I'll see more liver. Okay? So just, there's liver on my screen, right?
Yeah.
Look at my probe. Can everyone look at my probe?
Yeah. It's all the way pointing to
I'm looking at the table.
Yeah, looking at the table.
So from the xiphoid till
Look in here.
Yeah.
Like my, yeah.
والبريشر مش too much صح؟
See what my probe is? This is that's still liver. And I'm looking up, I'm looking up, I'm looking up, all the way up, all the way up, all the way up, all the way up. I'm still having liver, see? All the way up, and all the way up, and all the way, and all the way. I'm on the left now, see?
yeah.
I'm still having liver here. Look, there's a little piece of liver there.
Yeah.
See what my probe is? Look my probe. I'm looking what's underneath the chest, the body cavity, the chest cavity, right? So that basically tells me what? Tell me that there could be a liver nodule in here, that I miss it
Yeah.
by not looking all the way out.
Yeah.
So I'm sagittal now, okay? The other thing I look at as well, I look at the liver from the capsule.
Yeah.
I see how regular or round. You see that capsule underneath it?
Yeah.
Right? So you have also to keep a mind on that. Okay? I look at the echogenicity as well, right? compare it to the spleen and compare it to the fat and the kidneys, right? But let's go back in here. Now I got the liver, I'm gonna go transverse. How do I go transverse? I'm just go 90 degrees, right? And you have to do a lot of pushing. Same thing, you have to go all the way down, right? You see these stones, little stones in the, yeah. اللي شبه, yeah.
بس هنا في واحدة بشادو ولا لا؟ دي.
لا, the portal vein.
بس دي.
The portal, so really quick here, the portal vein and the hepatic veins on the ultrasound. So the portal vein has brighter wall to the hepatic veins, right? See this here?
We can freeze on the function.
Yeah, see that?
This is
where-
static on the left is the portal, right?
No, that one. Can you put color on it? It shouldn't take color. See that?
Maybe
The anechoic.
these vessels or the bottom? These
No, that's not vessel.
these.
The one that's not taking color is what?
The duct in the
It's a bile duct.
That's right.
It's a bile duct.
See, you shouldn't normally see it. But
Yeah.
why are you seeing it?
It's
Because
digestion.
we have some.
Because there's so many colors in there, right?
Digestion.
Yeah. So there you go. So what is your problem? Go back here. Go back to the duodenum. Go back. Here you go. Here it is. Here it is. What is this?
This is a bile duct. This is
A stone. What is this stone?
Bile duct.
no. This either in the pancreas or this in the bile duct.
No,
Let's see.
it is. It's in the. What is this organ?
This is duodenum.
Duodenum. Where is the common bile duct go?
Duodenum.
Duodenum. So this is right before it goes in. Okay.
يعني عندها كذا
At the
حاجة.
end of the bile duct.
At the end of the bile duct.
So maybe this is a problem also.
This is what's causing all your liver valves to be all the way up.
How we can solve.
It is almost getting obstructive there. And a lot of times you see this in cats, by the way. They go just stuck there. Because the papilla, here's the duodenum, and here's that little stone. The stone is sitting right at the papilla.
No, even it's going inside the mucosa, and you can see.
I'm sorry?
It's going in the mucosa. See that? The stone here,
Yeah.
and it goes
Yeah.
inside.
Okay, so the best way to get the papilla is to go transverse in the duodenum. Go transverse. Follow that. Keep following it. Stop.
There you go.
Here you go. Zoom in. Zoom in.
Zoom in, zoom in.
No, well, sorry. I mean,
Depth.
increase the depth.
Alright.
Okay. Keep going. Keep going. Keep going. Bring this up. Increase your frequency.
It's reverberating.
Increase your gain a little bit. Slightly. Slightly increasing the gain. Perfect. Okay. Now, freeze. Perfect. Go back one. Back.
Slowly.
Back. Perfect. That's it. So if you guys all want to know, like this is here, the duodenum,
Yeah.
the hamburger in the middle,
Yeah.
and that's the sandwich, right? That's the duodenum. If you don't know how, this is the duodenum from the location. That's the one thing, and also it's usually bigger, a little bit bigger than the rest of the jejunum. Okay, duodenum is here, all right? So the duodenum has the papilla, which all the common bile duct brings all the juice and dumps in there, right? So we know that this liver is making a lot of stones in the liver, and these stones are going in the gallbladder, and some of them are starting to move into the common bile duct. And this one is trying to make obstruction in here. It's just sitting almost at the papilla, right? So it's trying to make obstruction. So that's what's giving you all these increase in liver values. Okay? Right? So what you should do, you should try to take this in video. I'll take this in video, in and out, transverse and sagittal, and measure the common bile duct. Okay? Here's the papilla. Here.
Yeah.
See? Here it is. See? That here. Duodenum. Stop. Please. Stop. Okay. This is the lumen of the duodenum. This is the mucosa. Okay. One side mucosa, one side mucosa. And this is the submucosa,
musculosa.
muscularis, and serosa. So this is, you can measure this if you want, and measure this if you want. And the fact that I see all the layering details is telling me that there's no loss of layering details, which is good. Okay, and then as you see this, all of a sudden that circle comes in, and this is the papilla. Okay, so normally you should be able to, well, it's a bit more advanced imaging. If when you get good at it, you'll be able to see this in almost every patient. But you also look at this, and this is here where the bile duct dumps. Okay, so if it dumps here, and I have dilated common bile duct, what does that mean? I may have obstruction. Okay, so I have to measure it in here. So a very good question here is like, again, the vet doesn't care about all these things. He wants to know, go to surgery or don't go to surgery, right? So for you to tell him that, you're gonna look at so many criteria, okay? One important criteria is how big this thing is, okay? The common bile duct, okay? But also I have a stone there. So if this stone moves in a little bit further, you get full obstruction, okay? And this dog is gonna be painful, right? I also follow that if you follow this common bile duct, it'll be backing up, because once you have an accident on a highway, all the side roads will have accidents, right? I mean, back up. We have like, you know, traffic jam everywhere, right? Just like a stone.
A question, should we give a question?
Yes, can you please video that?
Yeah, just trying to follow it back to the gallbladder.
But also, it's good to put color on it for your records, just to show that it's not taking any color.
Yeah, it's not.
Okay, now you can measure this. Well, it's better to get the stone in there. See, like there is a stone here and one here, and you can tell that this one is not causing the obstruction because they're one's, you know, like one after one, right? I'll go like, if this is like that, I'll go like almost like.
Yeah.
It's okay. Perpendicular if you can. So there's a stone here and a stone there,
Yeah.
and there's another one here, right?
This should be by surgery or can be by medicine?
Well, we'll figure this out together now.
Yeah, here you go. So it's going all the way towards the cystic duct
See?
and the gallbladder and the common bile duct.
So it's a good picture. Make this bigger, a little bit bigger. Again, now you do more advancing imaging. You have to get good quality pictures. So you send it to a radiologist or send it somewhere. They can able to tell you. Yeah, just like go down, please. Like
Sorry, I will
change
just
your
make
depth.
Make it even clearer.
Yeah, that's his machine actually that he's working on. So.
It's more thickened here.
I'm sorry.
How about making it here?
This part is
I'll get a better image. Try to get a better image, please. Try to go transverse. You can actually visually see it here. You can see the two walls, right? Normally you should see like a fine white line, right? Once you're able to see this much, that's telling me that this is inflamed, right? That's another thing where we look, if we were suspecting mucocale, right? With mucocale, we also look at the gallbladder wall, okay? But what else can I tell about this one? Can we tell if it is like full ready to rupture or not from this?
Yeah, we can tell.
You can tell, right? Just like urinary bladder, you guys could tell that it's softer.
I mean, usually it is tear shaped like this is.
Yeah.
So it's still maintaining this tear shape. So I will say it's not really ready to rupture. So
It's
it should be round. If it is normal tear shaped gallbladder, it means it is still not ready to rupture. But if the tear shape is distorted as a rounded gallbladder with the mucocale, then it means that it's there. But it is, I think it is still far away from this.
Yeah.
I would say it's still maintaining kind of a little bit of tear shaped structure.
Measure that stone in there.
It's a good image for pancreatic bladder.
I'll just measure it like this.
From here?
Yeah.
And you want to measure it like this?
Yeah, like this.
البدي عندها حاجات كتير يعني.
Here?
She have a lot of issues.
Sorry?
This dog, she have a lot of issues.
She has a lot of issues, yeah.
Yeah,
See,
my stone
I wouldn't care
everywhere.
much about the other
Everywhere
side.
is stone.
But here's the thing, like this dog has so many things.
Yeah.
So do I call her, okay, number 1, number 2, number 3, you have your dog has 1, 2, 3, 4,
No.
20 things problem, and tell them there's a few other incidental findings in here. Okay? Same thing when you tell the vet, you're the one who's doing the ultrasound. Your colleague wants to know, okay, don't tell me 20 things, just what is the biggest problem? Here's the biggest problem. There are other incidental findings, and we should do 1, 2, 3 for them. But the current problem right now is this, right?
How to give a clinical manifestation يعني.
This is what's giving this dog that, being that clinically sick. So let's go back for a second and think. Okay, wait a minute. Yeah, so the one's obviously the,
The dilated one.
yeah.
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 So this one is a pancreatic between like this
Yeah.
one.
This is the upper
Yeah.
one.
But
Upper-
again, just like let's focus on the main problem right now. Just okay. Go back to this, please. Okay. So this is the stone we know in here, right? Right. So we have a stone sitting at the common bile duct, at the very close to the papilla, right? We have moderate size gallbladder. It's not severely full yet, because it's also important when you tell the owner or your vet, this dog has a colic and he needs it out. He's gonna ask you now or tomorrow. Okay, and how do they diagnose that? A few things, obviously, clinical signs, but also what you look in here. Well, how severe, how dilated it is, how big that common bile duct is, how much bright tissue around it. Remember we said about that bright tissue?
Yeah.
So if this is surrounding by bright tissue, wait a minute, you have to go to surgery now. I'm really sorry, you're not going for lunch, right? And can we all do this surgery? No, right? So this is a referral surgery,
Yeah.
right? That's the surgery that you send to someone good in surgery, or obviously a specialist if you have a specialist here, okay? But you better get this under control, because gallbladder rupture is bad, and most of the dogs are not going to make it if it does rupture, right? Okay, so yeah, we'll go back to the question. What did this dog have while you were in there?
While during the surgery,
Yes,
remove the gallbladder.
and
And,
get the liver biopsy.
oh, okay.
You were there.
Yeah.
Get a liver biopsy. It's so easy. Just put a suture around the tip and get it, right? I'll get like 2 to 3 loops if you can. It wouldn't take you a long time, right? But get a liver biopsy. Because you do this and you remove the gallbladder, everything went well, yeah, and then the dog liver biopsies are still high. What you gonna tell the owner? Well, let's go back and get a surgery. A biopsy, liver biopsy. Well, you were just there, right? Take it, even if you're not gonna send it now, but just take it, right? This dog may have something else on top of what he had, right? To put him through this, right? Okay, great.
So in such case, we just not removing the
I'll tell you what, if you do,
stones.
if you're no, you get the whole thing out.
Stones.
I'll get the whole thing out.
Gallbladder
Yes,
system.
no, I'll get the whole thing out. Yeah, but here's the thing, like, if you go to surgery for anything to the abdomen, to explore, and you don't find the reason on the spot, get biopsies.
Right, okay.
You're going for exploratory surgery, you open up the abdomen for a vomiting dog, and you don't find that foreign body, get biopsies, right?
It's an opportunity.
Get biopsies. You have the chance, right? But what else? And if you have any liver concern while you're there, now you got the adrenal. Don't measure it while it's here, especially if you have more room, right? So the way that he's got the adrenal, as we talked yesterday, get the kiva and fan up and down, and you'll find it.
But this cranial bone is slightly weird. It's tapering kind of.
Yeah. So the right adrenal can look like a comma shape, right?
I mean, it's kind of. Usually it just gets attached here. There's no tapering happening here, but it's kind of tapering at this end.
Just make it bigger.
Everything in the middle.
Yeah. At this point.
I think if you adjust your probe a little bit.
What do you think? What you see?
Try to go like this with your probe. Now, just also keep in mind that this dog needs steroids, right?
Not now. Not now. It's
Not now. Oh, okay.
But I think
Alright,
like
so-
the adrenal gland is fine, right?
It's fine.
right kidney.
I'll tell you what, things to be concerned about. Like, obviously, there's difference between when we're doing like an academic evaluation of an organ, and when we're doing clinical evaluation of an organ, right? You can tell me about the CM-REM, right? Cultural REM. And what do we, like decrease the details here and there. My question to you is like, what you're gonna do differently, okay? So if you find adrenal nodule in here, what you gonna do?
I will say
Measure it, document it, recommend whatever else. Okay, so if it is small, usually they say rule of thumb, right, for size of adrenal nodule. If it is usually, like bigger than 2 centimeters is likely cancerous, right? And most of these adrenal nodules are functional. So if it's a big and if it's like more than 2 centimeters and dark, we say dark is dark, right? Dark as in hypoechoic, heterogeneous, more than 2 centimeters, I'm gonna probably be talking to a surgeon, right? If it is big. But if it is like a half a centimeter, less than 1 centimeter, hyperechoic, as in bright, like that, it's a mass. It's not normal. It's a nodule. It's not normal. But from the size of it, from the echogenicity of it, we can recheck it again in 2 months and see how it goes. Okay? We're still gonna test for Cushing's for the function wise. Okay, obviously if we're clinical for it, but we're not gonna go crazy and call a surgeon for it, or we're not gonna put a needle in it. Anyone biopsied the adrenal before?
No.
Have you? Yeah, I did that one time, and I regretted that.
No,
Right?
right adrenal, how can you even FN in the right adrenal? Just right under the
No,
adrenal?
I biopsied the left before.
Left
Thank
you can do it.
yeah, thank God the dog lived. But if I go back, I wouldn't do it because the dog bled like
No, but how was
crazy. It was pheochromocytome actually, and as soon as I touched, I did find it. Yeah, so I
With
got
the
it.
FNA?
Yeah, yeah, yeah.
With the FNA blood?
Yeah, man, you touch the adrenal, right? Everything will go crazy. It's the adrenal gland, right?
You don't suggest to
I mean, even the surgeons, you know, were like so worried, obviously, because you touch it, like they go crazy, like, and the blood pressure and heart rate and everything goes crazy, right? But it was pheochromocytoma, and I sent it. I remember to a lab in I was in Canada at that time. She got him the diagnosis. They went to surgery. They removed it, and sent it for histopathology afterwards. But it was a 25 gauge, and it bled like crazy. You know, I don't remember if we had to give it a transfusion, but yeah. So don't try.
So,
If it's that big, that ugly, send it to a surgeon. Good luck. So the pancreas, I know like everyone wants to look at the
Doctor,
pancreas.
so how about,
where is the
right?
pancreas?
Pancreas is
How
easy.
come I-
That's the left one.
Yeah.
That's the left one.
So just, well, you're the right side now. So finish the right side. I normally for what I do, I move like counterclockwise. I stop here. I'll move to the stomach, pancreas, and the whole thing. So let's get that right. So this is here.
So basically, you guys can see this pancreatic duct that's entering as well near the duodenal papilla as well. So it's separate over.
You see this? Look at
Yeah.
this. Look at this.
Yeah.
There's little stones in here as well. Look.
It's in the pancreatic duct. Looks like.
No. It's in the.
Because pancreatic duct is here.
No, it's not. How would it go in the pancreatic duct?
There are cases of the stones in the pancreatic duct as well.
Migrating?
No, separate,
Yeah.
isolated cases.
But what's the chance of you getting pancreatic stones and?
Sorry, doctor. So this is non-pancreatic duct?
No.
Small.
I think he's looking at the papilla still. Go transverse.
I mean, yeah, it's still the papilla. It's bile duct. Is
Go transverse.
yeah.
There it is. See? Now you can tell. So look from a different, just like an X-ray. You know, if two people, you can see them. 2 people, 1 person on X-ray. I mean, different views, obviously, right? Lateral versus VT. Right? Makes sense here?
Yeah.
Here it is, right? So, good thing you guys scanned this one. Now, follow that pancreas all the way. And what we're looking at pancreas, like when it is pancreatitis, you'll know it. Obviously, if you're scanning enough, you'll know it. Again, you'll find bright tissue around it. Bright tissue is telling you, here is the problem. Okay? Bright, dark. That's it. Now, if it is pancreatitis, you look at it, you measure it. If it is thick, you biopsy it, right?
Yeah, sorry. No, it's the right limb of pancreas. Yeah.
So how do I know it's the right side?
It's below the duodenum.
Because there's duodenum around it, right?
There's a longitudinal. Yeah. Let's look at the. So, we're going to do the pylorus as well.
Yeah, oh, very good actually. Thank you for doing that. I almost forgot. See, you just want to part of the exam in here, this area, is to get the pyloric outflow.
So this is the pylorus.
So when you're having obstruction, so it's so important that you look at this shot in here.
pylorus.
Okay. So this is the. Can you bring
It's
it?
the duodenum going towards
Okay,
the...
go to the pylorus again.
Yeah.
So this is the pylorus here. He's gonna move back slowly. Slowly, he's gonna come to the
Duodenum.
duodenum. Here it is. Here it is. Okay. So you're moving from the
Duodenum to pylorus. Or
pylorus to duodenum or the opposite, right? You can do that in sagittal and in transverse as well.
In constipation cases also it could be like reverse peristaltic movement from duodenum to stomach. And this is one before.
Okay. So whenever we see, okay, if we have foreign body, that's mechanical obstruction, right? So that mechanical obstruction in the duodenum, or like mid-jejunum, likely you'll see this dilated with fluid. If it is further down, like later on in the jejunum or ileum, you may not see that dilated. That's number one for mechanical. But let's look at ileus as well. With ileus, which is functional, it's not mechanical, it is functional. The stomach got so much dilated and just flaccid and it can't contract. Okay? A lot of times you'll see that just like a lot of fluid here and there and everywhere. But the whole thing about it is to follow it. Follow it here and follow it all the way down to the rest of the intestine. And when you're doing your zigzag, you're not going to find anything.
So for ileus again, can you illustrate it? For ileus, if it's functional.
If it's functional,
Yeah, what should I say? The looking of the intestine.
it can be in the intestine and it can be in only the. Sometimes it can be in the intestine and the stomach. Sometimes it can be just in the stomach.
It will be dilated.
Yes, it can be. Yeah, but you'll see that from the movement. You'll see the stomach just sitting there doing nothing. But keep in mind that you still can have dilated stomach sitting there doing nothing from mechanical, but you missed it from mechanical, which is in foreign body, right? So do not miss that foreign body.
But you mean here dilated for the stomach or for the duodenum and the intestine?
Both.
Both of
Both.
them.
Yeah, yeah. But what I'm trying to say is sometimes all you get is dilated gastric outflow. All you're getting. Because the foreign body in the duodenum and the dog is so much deep chested and you can't look deep enough and you didn't shave here to look from the intercostal space and all you get is just that dilated pylorus. So whenever you have dilated pylorus with fluid, you must follow the duodenum all the way, okay, to make sure that, because these dogs are not going to show on x-rays. On x-rays you only see dilated stomach, nothing in the intestine, because the foreign body and the duodenum, right? You have like a mid-duodenal foreign body, or proximal duodenal foreign body. Every intestine aboral to that is going to be normal, right? But oral to that is going to be dilated. Yeah?
Specific measurement.
I'm sorry?
Certain measurement.
I know you know that, so. Yeah, Dr. Naam does a lot of scanning, so. I'm sorry?
Beginning of the second colon.
Colon, what is this? Here?
Pancreas should be pancreas.
Pancreas, here?
Yeah.
Pancreatic tissue, that a little bit darker in here? That?
It's a part of the liver, I would say.
Yeah, that's liver, yeah.
Yeah. But the pancreas should sit here.
Yeah.
Doctor,
Here.
Yeah.
Doctor, how can I detect the pancreas? I don't know.
So the pancreas, it is so.
This is the one.
Yeah.
I think this
So if it is inflamed, you'll be, first of all, you need to know what it is and how to look for it, okay? So if you're scanning this area and you're not seeing it, just scan the area and try to take a video of it to show that you scanned the area and there's no evidence of pancreatitis. But if it is inflamed, you'll see it dark with bright tissue around it. Dark with bright tissue around it, okay? And it will be painful, right? And that's how you're gonna know it. Sometimes you can see fissures through it, like anechoic fissures, and these are fluids when they start to get so much edematous, edema.
Of pancreatitis in the machine.
Awesome, yeah, we can
You
take,
can play this video.
sure, once we're done with that one, we look at the pancreatitis. Since my computer, I brought my computer in to show you guys some of the fun stuff. Cancers to grow, right? Between the ileum and the colon, especially in cats.
I know this one.
Especially in cats,
Yeah.
right? So,
Looks like, I don't know what it
follow this. Again, back to what we're trying to say is like, if it is abnormal and you keep, like he's looking here, right? Make mistakes when you're looking for it, you'll see the gastric outflow stomach and duodenum, and you'll think that this is it, but it is not. Okay.
Can you freeze
Here is the ileum, and here is the colon. And how did he know? He followed the colon to the end, and then he kept moving back and forth until he saw the ileum.
This is the ileum and this.
Like a small. From here, it's not gonna show, but just try to video it, please, or just play what you have done. Here it is. Okay. So, okay, follow the ileum. Follow the ileum. Follow the ileum. Follow the ileum. Follow it. Follow it. So we know that this is small intestine. Go back. Okay, give me that part of the ileum, please. And
the size of layers
yeah.
is different now.
Stop. Yes, from the
Start
layer.
to do-
Exactly.
yeah, from the layers, yeah.
There you go. So the layering, I know that this is
Start
not
to do bigger.
colon. I know that this is a small intestine layer,
Uh-huh.
and it is going into the colon. So I know that this is the ileum.
Yes.
That's all. Here you go. Here you go. Okay.
I just moved the transfers to make it better.
Normally, it's easier for you to find it in transverse. And honestly, any organ, it's easier for you to find in transverse than lateral.
So it is.
Sorry.
Okay, dog, have you zigzagged the dog? Okay, can you go back to that intestine?
Sorry.
Okay, go back. Go back to this one.
Judgment.
Yeah, just
Here you go.
here. Give me that one.
Alright.
Long, make it long, and make it 3 centimeters if you can. Okay, go further. Just 3 more. Perfect. And okay, so increase your frequency a little bit.
It's highest.
That's highest.
Yeah.
Okay. All right. Go back. Okay. So just keep it sagittal. Keep it sagittal, please.
This is better. It's the valve is beating there.
No, I'm not. I'm not looking for. I'm looking for something else.
Like
I want this. I want to show them something different. Stop here for a sec. Stop. Freeze. I mean, go back. Freeze. I mean, freeze and then go back. Slide back. Back. More. More.
No, that's
It's
it.
finished.
That's it.
Yeah.
All right. Anyways, so don't answer, please. What is this in the middle here?
This is the lumen.
Lumen. Yeah. This.
Mucosa, submucosa,
The wall.
musculosa, serosa.
Good.
So
Do you
this
see
is
that
the
mucosa in here?
Larger?
Do you see it?
Yeah.
I don't know. I haven't measured it, but subjectively it's normal. It's about 3 or 4 millimeters. But see,
Yeah.
see these little dots in here?
Uh-huh.
So you have to keep an eye on these. Okay. This, for this size of a dog, this age of a dog, it's okay. But sometimes be lots of stickling, and that's
Yes.
a hint. It's telling you there's a problem here. Okay. You can see that with inflammatory bowel disease. You can see that with lymphangiectasia. The little Yorkie.
Yeah.
But that is very bright. The lymph
It will be very bright.
The
You will
lymphatic
see like this picture in here.
Do you mean?
It'll be like more like this.
Do you mean hyperechoic foci or something?
Exactly,
Like that?
hyperechoic foci in the
Yeah.
mucosa. It'll be like a lot. You see, like almost it will look like this.
I think it depends
Uh-huh.
on machine settings as well.
I'm sorry.
Machine settings.
Yeah, that's why like I asked him to make this 3, increase the frequency and do all that stuff to be able to tell. But the fact that I'm able to see the differences from here to here, and I'm seeing this, that's telling me these little foci, right? You're able to see them. So if you're having a lymphangiectasia dog, you'll see almost this, like so many of these.
Yeah.
In a dog like, you know, a Yorkie, hypoproteinemia,
In case of
peritoneal effusion.
IBD is like this. How to make a decision? Because sometimes I see this one
IBD is
in the normal animals as well. Really.
yeah. So is IBD a macroscopic diagnosis?
Not really.
No, it's a microscopic diagnosis. Even like the whole thing about this ultrasound is like ultrasound is still a macroscopic diagnosis. It's not microscopic diagnosis. It doesn't give you a
Some
microscopic
animals come with
diagnosis.
IBD scanned and they're interested in perfectly normal.
Yeah,
You
it
don't
give you
find me.
it give you a hint.
I mean,
Okay, and to get good at this, I saw this, for example, not this, I mean one like with worse spickly, and then I think, okay, this may be an IBD, and I go and surgery, I collect samples, I send it out, it comes back IBD. So every time you're getting a sample, you send it to the lab, go back and look at your images. So now you have a relation.
but I have seen some normal animals as well, young animals.
Yes,
They come. So
Yeah.
How
Yeah,
do
yeah.
you put your?
Yeah, that can be normal from like an antigen reaction and all these
where do
things.
you
Like
put
when
your
they're,
bar there?
the same thing like you're having a little bit of lymphadenopathy, like increased lymph node size in the little animals when they're growing.
I usually
The antigen
just,
reaction.
I usually just ignore it unless they're showing some clinical.
So,
I just let it go.
so there's a difference between reporting and taking an action. So all I'm gonna say in here, and that's the difference. That's why I brought the computer in here. So when you're describing, the first part of my report has the description. So, for example, if I see a lot of these, I'll say, okay, well, there's mild or moderate or severe hyperechoic spickling, the small intestine mucosa in one section, or many sections, or the entire intestine. I have to describe that. So you have to describe that, okay? Mild, moderate, severe, 1 or 2 or 3 or 10, whatever, right? So I describe that. That's my description. Then the next part, I'm gonna put my differential diagnosis. Well, based on what I see, I think this dog may have inflammatory bowel disease versus lymphangiectasia versus whatever. I put all my differentials. But now after that, I put in the comment, what do I do for it? Okay? Is it something that's worth or should take an action for it, or just ignore it, as you said?
Clinical signs.
Or recheck it, clinical signs. Thank you.
Clinical signs.
Right? Clinical signs. This dog is like vomiting every now and then. Every 2 weeks, I'm having a vomit here and a vomit there. Well, maybe this is one that we should be.
One
So
thing is
we
that
need now
looking there and looking here, it's like
It's different.
a little bit different word.
It is different. Yeah.
I mean, here, if I have to look at this, I mean, if I'm
You'll
doing
adjust it. Yeah.
if I'm
Yeah.
doing a general scan and like busy practice day and stuff, maybe I will just like put it as. I will not probably notice it.
Clinic nodule in here.
But it looks like a target lean,
What?
hypoechoic.
Target?
Yeah, looks like.
Yeah.
And hypoechoic center.
So if we didn't do the zigzag, we could have missed this one. All right. We asked earlier to do all the spleen, and I think you said you did the spleen, right? You did all the spleen. But here's the lesion, right?
Yeah.
Okay. So the next question will come to this. Again, you're the sonographer. The surgeon is Dr. Blue. She's gonna want to tell you, okay, will I see it in surgery? She's gonna ask you, will I see it in surgery? You gotta tell her there's a spleen nodule. All right.
predictive signs as
Would I see it, would she see it in surgery?
No. Put her.
This one, she's not gonna see in surgery.
Yeah.
You know why? Because look at the capsule.
Capsule is
It
just.
looks normal. Go transfers on it. Go transfers. It's not changing the capsule, so she's not going to see it in surgery.
I think it's better to put an FNA because spleen.
So this is one thing that you're gonna want to get a fine needle aspirate from.
For me, the spleen looks slightly coarse by the.
Coarse?
Yeah, slightly. Ecotaxin is slightly coarse.
Okay. So let's just.
I mean, it's not looking that coarse here, but if you look here on the screen, it does look quite coarse spleen. So I can say it's worth putting a needle into this.
Yeah, that's something warranting for sure putting a needle in. But then what will make you different than other sonographers is your gut feeling. Okay?
My gut feeling is just okay. It's not a nasty thing. I would
It's
say.
not a nasty thing.
Yeah.
That's my gut feeling too, right?
Yeah.
Because it's only one. It's
Yeah.
single. It isn't the spleen. If this same one was in the liver with that target lesion that he's talking about, I'll be concerned. But it's also one. If I'm having like 3 or 4 target lesions in the liver, I'll be like, oh, that's a concern. I will never give a microscopic diagnosis. Like our gut feeling is just our gut feeling. What does it mean, our gut feeling? Yeah, it doesn't mean a lot. It just gives you my experience, because now he's gonna put the fine needle aspirate in this one, and it's gonna come the results after 3 days. When the results comes in, he needs to go back and look at the images and look at this. Oh, okay. And if he keeps doing this thousands of times, he will develop like an idea of how things would look like. But is there a study to tell when they look like this, it is that? For this particular one, no. So we can't be able to give them a microscopic diagnosis from a microscopic. Now, what if this one was bright?
Bright. If
Yeah.
it is bright and along the vessels, myelolipoma
Myelolipoma,
in a
right?
rigid duct.
So if it was bright, it would be like really bright around the vessel, as he said. This, like almost most likely, myelolipomas.
Very common in the old dogs.
So we'll just leave him alone. But because it's dark, he wants to poke it. He was concerned about, what was your concern?
Targeting.
I'm sorry?
Metastatic separate.
No. What's your benign things, differentials?
Benign, nodular hyperplasia.
Nodular hyperplasia.
Yeah. And then
Extramedullary, you said extramedullary hematopoiesis, right?
Extramedullary hematopoiesis, yeah.
Extramedullary hematopoiesis, right?
Because of the coarse ecotexture.
Yeah. So, there are so many benign things, lymphoid hyperplasia, extramedullary hyperplasia, or whatever. So many benign things that can give you that kind of picture, but
I think when
you
the first
cannot
time
give a
I saw
microscopic
this texture
image.
first time and I 100% said, this is tumor, it's a coarse ecotexture, but when you took the sample, you sent to the lab, it's a hematopoiesis.
Yeah, and that's, like I mentioned yesterday, like I've removed a 16-pound tumor from a spleen, a splenic tumor, a spleen from a dog that was 16 pounds. Big mass, came in for hemoabdomen, bleeding, okay? And I sent that histopathology, in my hospital, it was a referral hospital. I sent it back to the vet after the dog recovered or whatever. The vet, the RDVM started chemo. I was like, how come? You cannot do that. It came back benign. 16 pounds. Benign. And that was like bleeding, ruptured. I couldn't even I had to make a big incision to get this thing out. The dog lost 16 pounds just from that, removing that spleen. And it was benign. So you cannot give a microscopic diagnosis from a macroscopic picture.
The ultrasound of the liver is not complete as long as you do the vascular study from my side.
The what?
As long as you do the hepatic vascular study. It's not complete. You should.
Not that.
This is a vena cava.
No, that's the portal vein.
No, this is a vena cava.
Oh, okay, yeah, that's not to the kiva, yeah. But you're pressing too much.
Yeah. Aorta is there.
Make it long, please. So sometimes with these guys, I have to put them on their back for that. Put them on the back will be easier for you to get it.
Really?
If you put the dog on the back.
For me, that is easy.
Sorry?
Like this. For me, that is easy.
Yeah, for you, okay.
Yeah.
But try, if you're having a hard time, try to do that, and then you'll.
Because usually I can reach the gastroesophageal sphincter as well from this position.
Yeah.
You can get it go in and kind of. Yes, then you start.
See, when you start to look for the caudal vena cava, portal structure, everything else will be easier. Oh, adrenal comes, don't worry about it. Good kidney picture, don't worry about it.
Shunt hunting is interesting basically. And then you can follow it inside the liver as well to see if there is some shunt coming there.
What time is it now? 1:15?
I don't know if anyone else wants to start this. Okay, they're not interested in doing this.
I think just for. Please. Go back slightly. Stop talking, please. Sorry. Hold it, please. It's not my machine. Okay.
Which one is this on the bottom?
That's the.
The first one is the gastroduodenal vein.
Yeah, so this is the portal vein, where it goes to the head.
Oh, okay.
So that one on the bottom here is the portal vein.
Sorry.
So that's what you measure. Okay, because blood is coming from the gastroduodenal, joining the portal vein, going just to the liver. So this part, you measure it from here. And remember the aorta, you divide that to the aorta.
Yeah.
It has to be more than 70% of the aorta.
Yeah.
And if
When you have a shunt, sorry,
that?
when you have here's the splenic vein coming this way, okay, but when you're having a shunt, sometimes you'll see it's going like this, portal vein size, and all of a sudden it drops in size.
Yeah.
Right? Because the blood is leaving before it goes this way.
What
Volume.
is better to for the shunt follow the portal vein or follow vena cava?
Follow the portal vein. Yeah.
And then follow.
And then you follow the shunt itself to the cave. Yeah. So it's more like advancing, imaging and.
should be more than a water, right?
No, it should not be. If the aorta is 1 centimeter, the portal vena cava at the highest there.
Yes.
Not before, because it's harder to get it down there. So some people can't get it there, but you want to measure it after the gastroduodenal vein, because the gastroduodenal will dump more, right? So after the GDV, you measure it, and you take that number and divided by the aorta, it should be more than 70%. 70. Yeah. So if you have a 1 centimeter aorta, it should be 70. Good.
If it's decreased in size,
Yes,
the
you
pilus
fix it.
itself, so
Then where is the blood going? Yeah.
Yeah, shunt.
Yeah.
Because
It's
it's
shunting
decreasing
somewhere
size.
else. Yeah, it's going to the cava.
Yes.
And sometimes you can just follow it. It will be like a funky vessel going all the way up to the cava. Good.
Subjectively
Get the next
speaking,
victim, I'm sorry?
If you can see the portal vein and the portal hilus, it pretty much rules out the external condition.
It's what?
It pretty much rules out external condition.
Not if you
see
can-
the portal vein easily at the portal hilus.
No size. You should be able to see it.
If there's a shunt, I mean, it will be hard to visualize it.
Depends how big the shunt is. But you still should be able to see it.
Yeah.
I've seen it one time with like 40% of the aorta. I've had some that were 40% of the aorta, right? Like really small, but you still should be able to see it. So we move to the next one, please. Next victim. What else are we gonna tell them about the kidney?
Kidneys.
Remove the kidney.
No, just
No.
changes there. You
Okay.
still don't see one.
What?
Drinking.
So I'm gonna tell them there's a cyst in the kidney. What else abnormal is in the kidney?
There's
Details.
Okay, let's see if we were to write this report in here. We're gonna describe everything that we talked about, and after the description, we're gonna list the abnormalities. If you have my computer, number 1, and then I start with the most important. I'll say 1, gallbladder, and then I already described what's going on above, right? So I'll say multiple ducts seen throughout the biliary tree and the gallbladder and in the common bile duct, very close to the duodenal, very concerning, with thickened gallbladder. So much dilated, thickened wall, hypercoagulated tissue around the common bile duct is like half a centimeter, 0.7, 0.8, and the dog is clinically showing me clinical signs. The blood work is showing me, everything is telling me I'm ready to rupture. Sometimes you see like a fusion around it, a little bit of fusion. These are the ones that I'm going to tell them go to surgery now. All right, now. Right? That's when you have to be like certain now. Okay, but when you see the for this one, I'm gonna say as soon as possible, right? If it has a mucocale without dilated common bile duct, without, and that I'm able to still compressible gallbladder and everything else looks okay, that these are the ones I'm gonna tell you know what, recheck it. Maybe you can try some medical management and recheck it later on. Okay, but so you have to differentiate your diagnosis. You're not just doing ultrasound. Because for me to send you a case, I want you to tell me you're the expert, you're the ultrasonographer. You have to tell me what to do. Okay, surgery or no surgery and when. So now we know when to tell them go to surgery now, go to surgery in a couple of days, or keep an eye on it, medical management later on.
Internal medicine and sonography go hand in hand.
I'm sorry.
Internal medicine and sonography.
Exactly.
They go hand in hand.
Like honestly, when I had my hospital, like you know, like we used to have people flying from different provinces to come and get an ultrasound. Why? Because they know that they're getting to know what to do afterwards. The internal medicine part of it, right?
Yeah.
Right. So that the other thing too is okay. So we said the gallbladder. We talked about it. Then we're gonna talk about liver. Then number 2, I'm gonna write liver because I think this is the second issue, right? I'm gonna put like mild hypercoic tissue, hypercoic liver, okay, with several calculi, seen throughout the biliary tree, okay. But my recommendation will be based on the current liver values. Liver biopsy should be considered while in surgery, okay, plus bile culture. So we talk about gallbladder, liver. What else do I have to say? Now what's number 3? Spleen. I'm gonna say spleen, hypocoic, heterogeneous, small, single nodule seen in the spleen without any change in the capsule. That means the surgeon's not gonna see it. Fine needle aspirate is recommended and was done in ultrasound. So this is the one that I'm gonna put a needle in it, right in there. I normally at least get 2 to 3 pokes, not samples. So sometimes with one sample, I spray it over 2 or 3 slides. Okay, I use the woodpecker technique. without the needle attached. Boom, 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 boom. Just 3 or 4 times in here. Get it out. Connect it to my syringe. Spray it on a slide. I still have more. I deattach the syringe, fill it with more air. Attach again. Spray it another slide. Spray the spread, and send it to the obviously dry it immediately. Send it for histopathology
From the spleen.
from this particular spleen.
And it's okay to find needle aspiration from this.
Yes. Yeah. Actually, you should. That's what recommended, right? Right? Bless you.
Guided by the ultrasound.
I'm sorry?
Guided by the ultrasound.
Guided by the ultrasound, yes. And honestly, like yes, you should actually, like no problem.
Sorry, if
Bleeding?
you miss the medulla and you rupture the spleen.
You're not gonna rupture the spleen. I'll tell you what. I'll tell you even something worse. Liver, for liver, I go with 14 gauge core biopsy. You know what 14 gauge? How big it is? Yes. Exactly. And I don't get it from one lobe, I get it from multiple lobes, as I just told you. Okay? 14 gauge. You know what comes out after I do this?
Yeah.
It comes out like the roundworm?
Yeah.
Just like the roundworm, right? This side. And guess what? They do bleed. Because they're supposed to bleed. If it doesn't bleed, the dog has to be dead then. Right? They do bleed, but it's okay.
But they don't bleed the dog.
I'm sorry?
They don't bleed to death.
No, I mean like the dog, if the dog didn't bleed, that means the dog is dead. That's the only reason. Actually, that probably will bleed even if the dog is dead, right? So it's normal, it's okay. So bleeding is not the end of the world. I'll tell you what, I'll tell you even something better. Like we put needles, we were talking about yesterday, we were here yesterday, right? We put needles in the lungs. Oh, you did? Okay. So we put needles in lungs. In the lung. Okay? But not in the aerated lung, in the wet lung. So there's dry lung and wet lung, right? Dry lung is the normal lung. Wet lung is lung with pathology. So you get the lung and you find a nodule with your ultrasound, put the needle right in this. Okay, forget about the nodule. You're getting this dog with like bad respiratory problems and interstitial alveolar pattern on X-ray. You get alveolar pattern with air bronchogram. It looks white. Okay? And you're treating this dog with antibiotic. The dog is not responding. You know what's happening. You want to culture this dog? Put an ultrasound probe on it, find that tissue sign, and put the needle in it. You're getting it right from the source. You're getting this for cytology and for culture. I'm sorry? Well, you can do bronchoalveolar lavage, or you can get it right from the source and hope that you hit what the main problem is. Or you can get it right from the source, right? So the BAL, you're going in there and hoping you get enough sample or representing sample or you know what you're getting. But when using a 25 gauge into that tissue sign, it's right from the source.
Yeah, if it's consolidated lung, though, we can see why.
Yeah, it's to me, maybe because I do ultrasound, so I vote more for that. You don't have to sedate the dog. You don't have to anesthetize the dog, I mean. Right? With BAL, you have to intubate the dog and use the scope, and not everyone has a scope. But you can just do that lung fine needle biopsy using a 25 gauge. 25 gauge, the dog may not even feel it. But for that one, I'll ace torb the dog, or midazolam torb the dog, or just high dose torb the dog, so it's not moving, and it's so quick the dog even haven't realized what's happened. And you gotta, like, honestly, this is the best, easiest, most accurate way to get a sample, just from the source, from the manufacturer, right? Culture it and cytology. So going back to the spleen, absolutely, this is a spleen biopsy. Okay, what else should I list in there?
Kidney.
Kidney. So I'm gonna put kidney. What's the problem with the kidney?
The cyst.
Okay, so for me, I'm gonna list number one. Sure, cyst-like lesion in the right kidney. Measure this and this and this. My recommendation for it will be monitor. Recheck. When would you recheck?
After 2 months, maybe?
Yeah, 2 to 3 months is fine, right? And see the size, okay? Or earlier if we're showing any clinical. Always I say, if I ever say recheck, I always say or earlier if so and such, okay? Yeah, if you practice in the States, you have to be worried about how many people will sue you if you say the wrong word, right? But not necessarily that, but you also have to tell the people of what to do, right? So if this dog all of a sudden is having urinary problems or, you know, PUPD, let's take a look again and see. I'll also put that corticomedullary details, mild decreased corticomedullary details. Would you call this mild or moderate? Probably moderate. Yeah, I'll probably call it moderate. Sometimes I write mild to moderate if I, you know, want to be like fancy. Mild to moderate decrease in the corticomedullary details. La 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 doesn't mean oh la, have a good day kind of thing, right? So keep an eye, do urine test. I'm gonna tell them do urine test and culture, right? Because I don't know what caused this kidney to look like that, and I may not really know what it is. And honestly, kidneys aren't that great with ultrasound. Like picture, unless you're seeing a tumor or a stone, right? I'm gonna also mention that there is some. I'll call this mineralization of that one kidney. Was it one kidney or both kidneys? One on the left kidney. And this is probably this mineralization is what's causing that cyst. Okay, I'm gonna write how big it is, but not necessarily. Just like for the records, how big it is, but my recommendation is to do UA and culture. That's number 4. Number 5, I'm gonna write what else? Thank you. I was seeing if someone will see it or not. What would you write in there?
The blood clot.
Yeah. So there is a suspended hypoechoic. I wouldn't call it blood clot because a blood clot is a diagnosis, right?
Yeah.
So a suspended hyperechoic. Floating irregular size this and this lesion, I call that lesion, right? And the bladder, no blood flow detected through it, not attached to any wall. Likely this is a blood clot, right? And then I'm gonna write what else in the bladder?
Sediments.
There was 2 sediments.
The sediments which is floating in the urinary bladder lumen.
Yeah, I'll say like a sediment line, measure like 1.5 centimeter sediment line, shadowing. Okay, another a smaller one that looks like probably a stone, measure whatever that was, right? So maybe, but we forgot to scan the dog while it's standing. See, like you always to scan the dog standing. Standing, right?
Yes.
Remember we said that? Yes. So these are the things. Like before the dog leaves, I how many problems I have? Now we have about 5 or 6 problems, right? 5 or 6 problems. 5. Okay. So anything else we found in there? We zigzagged and we didn't find anything, right? So.
But we already. Sorry for the interruption. We already took it on the.
Yeah, I'll still do it standing. Yeah, I'll still do it standing as well.
Still.
Yeah, yes, because I think there's one that needs to be surgically done. Like there's one that's about 0.5 centimeter, right? And if it is that big, may as well just get it done. You're going to surgery anyways, right? Right? Unless if it is urine sample tells you something else. So I'll say urine sample was collected during ultrasound using cystocentesis, sent for analysis and culture, and and go from there, right? So. That will be mentioned in the under the gallbladder, bile, common bile duct talk, right? So, and then I write my report, and then I'm gonna talk to the vet, the referring vet, tell him, okay, your main problems are the gallbladder. When you're in there, try to deal with the your main problem here is the gallbladder, right? Try to get it out. You should try to get it out. Culture it while you're in there. Get liver biopsies while you're in there. Ideally, send them. If not, keep them at your clinic. So if the owner tells you I don't have money for the liver biopsy, we'll tell them, okay, well, just take it and keep it in case we don't have an answer later on. Now we can always resend it. Okay. And culture the bile is so important. Culture the bile.
Sorry, if it doesn't have
the bile. Yes.
But with liver.
The bile. I'm sorry? So you have higher chances of culturing the bile, growing something from the bile than you have from the liver.
Yeah.
It yields more, the bile itself, yeah. Okay? So whenever I'm doing the core biopsy that I talked to you about, I still go in the gallbladder within the gallbladder. I pull, but that bile I'm getting, I'm sending for aerobic and anaerobic culture, both. But when you're going to the gallbladder, go through the abdomen or through the liver? Poke the liver or poke the abdomen?
To decrease the bleeding, the leakage.
The leaks, is correct.
From the liver.
Through the liver. So go through liver. After liver, you get a gallbladder.
And for the urinary bladder, the urinary, not the gallbladder, for the urinary bladder, it's recommended for surgical treatment to operate on.
Yeah, so we forgot to check him again when he's standing. I wanted to know if that 1 centimeter long sediment had any particular stones in it, because if it did, I'll definitely recommend him going. But honestly, like, I think there is enough sediment in there that may be warranting taking a surgical, and we're going to surgery, right? But I can't comment on that and say yes or no until I do it while standing and check it really well and being able to isolate and see the biggest one. If the biggest one is big, I'll go get it surgically. I'm sorry?
Sediment will become fine in the medicine treatment as well.
I'm sorry?
It's only sediment. It's going to become fine with the medicinal treatment as well.
Yeah. So if it is sediment, you might be able to get it with medicine, right? But also here it comes again. Okay, well, let's say if the biggest one is 0.4 centimeter. Okay, do I try medicine, diet management for 2 months while the dog is going through surgery anyways, and then put the dog again through surgery that's 11 years old, or should I go in there and remove it immediately? So that becomes more of a a dialogue.
You mean sediment 0.4 centimeters?
No, there is one thing that looked like one. It was single one.
Single one.
I think, but I have to do standing. I'm sorry?
It was not big enough to be sent for surgery.
I'm sorry?
It was not, how big it was? That time
I think it was 4 millimeter, I think.
It should go for surgery?
I'm sorry?
It should go for surgery?
Well, would it pass?
It's a female dog.
Yeah, well, it might pass. It might get bigger, right? How about the other ones? Are the other ones, do they have anything that's 8.8 centimeter? I don't know, because I haven't, done that shake well. So shake it well. If you have big ones and you're concerned, then you can, or if you're concerned, right? Because sometimes, for example, it's like going to spay a dog and do a gastropexy at the same time.
I mean, she's not going to get obstructed anyway.
I'm sorry?
Female dogs most likely will not develop.
Yeah, but that one that you're gonna leave will get obstructed, I assure you. The one that you tell the owner most likely is not gonna happen, this is the one that's gonna happen, trust me. How many times have you seen an obstructed cat, female?
No, I haven't seen that.
I have seen it, and I couldn't believe my eye. It's a blocked cat coming in, and it's a girl. I was like, are you sure? I was like, yep. So the one time you tell the owner it's not gonna happen, I'll tell you what, I was in New York, I think, one day working, and I get this dog. It was a German Shepherd, and they came in for a GDV. The girls, the dog is having GDV, coughing, hacking, nothing coming out, not productive. German Shepherd GDV. So I go in there, I examine the dog, I put my hand around the dog abdomen. I feel like almost my hand touch each other. So I told the owner, I feel my hand, just not a GDV. But we're just taking an X-ray just in case. And I take an X-ray, and guess what? It was GDV. I have no idea. Because the German Shepherd chest is so deep, right?
Also,
It's tucked in there. It just happened. Owner brought him in so fast, and it just happened. Owner is educated, so brought him in so fast. But what's the question learned here? It's like, do your due diligence. Never say never, right? Never say, it's definitely. So never look at this little spleen nodule. It's single spleen nodule. It's benign, yes, because it's 99.9% benign. But the 0.1111% when it comes in, it will have a Another thing I have to recommend.
No, as I say, lunch is
Lunch?
ready.
All right.
So
Recommend go to lunch.
Continue the discussion, but you can eat it.
Yeah.